Welcome to the NWAATC Project Echo. I'm Kent Unruh, and I'd like to turn it over to our guest today, Dr. Eudelis Flores.
Thank you, Kent. I am an associate professor at the UW in psychiatry and also the new director of psychiatry at Madison Clinic. And we're going to talk today about HIV psychiatry or mental health and people with HIV. And the outline is we're going to talk a little bit about the prevalence of mental disorders in people living with HIV, some of the common screening tools we use for mental illness and addiction. We'll talk a little bit about the complicated interaction between mental illness, addiction, and adherence problems that are so important in HIV care. A little about the psychopharmacology of our medications and what medications we like to use with patients with HIV who have psychiatric problems. And finally, a few of the P450 drug interactions that we have to be concerned about when we're prescribing psychiatric medications with the antiretrovirals. First of all, prevalence. The lifetime prevalence rate, of HIV in mentally ill inpatients and outpatients is reported to be between 3% and 23% in various different studies. That's a big range. And it probably has to do with the fact that those who are inpatient, for example, happen to be more acute, more severe than those who are outpatient. It depends on what type of clinic the mentally ill patients are in, and of course, whether they're urban versus rural. There's different reasons, but it's thought that people with mental illness, and of course also people with addictive disorders, have more behavioral risk factors for HIV. And also, some people who are mentally ill are more likely to be victimized on the streets, in particular when they're homeless, which of course will increase the risk of infection. Now, how about the prevalence of mental illness in those who we see who are living with HIV? Well, according to a big national survey, this is very large and it's a household survey across the United States, about 48% of people with HIV screened positive for psychiatric illness. Depression is perhaps the most common psychiatric illness. It's about a 36% 12-month prevalence in those with HIV, and that is a 5-fold increase in prevalence compared to the general U.S. population. PTSD is also more common, and there's a 20% 12-month prevalence. Generalized anxiety disorder is quite elevated. That's a 16% prevalence compared to the general population, which is about 8 times less than that. Substance use disorders actually are a little bit more common than even depressive disorders in that population, and about 40% of patients with HIV reported using an illicit drug other than marijuana over the previous year. Drug dependence, that's not abuse, but dependence, is about 12% prevalence in the HIV population, which is a 4 to 6-fold increase over the general population. Some of the screening tools for mental illness that we use in the primary care setting are the following, and of course the PHQ-9, the Patient Health Questionnaire, which screens for depression, 9 questions. Actually, it's 10 questions altogether. And we do that regularly here at the Madison Clinic with every visit. We also often use the GAD-7, which is the Generalist Anxiety Disorder Questionnaire, a 7-question questionnaire that's very brief and easy for patients to fill out. And there's PTSD screen that I like to use for primary care patients, and it's a 4-question screen that is quite effective, quite good at identifying people with post-traumatic stress disorder. And this is from the VA population and also a civilian population that this has been tested in. And you can see the questions up here. There's 4 different questions, yes and no answers, and it's considered positive if there's 3 yes answers, and that's been studied and has good sensitivity. Finally, there's all sorts of addiction screens that we could do. You know, of course, there's the CAGE or the CAGE aid, which is for both alcohol and drug use disorders. Then there's the audit and the audit SS, which is a short screen audit that we use, and the drug assessment screen as well. But really, there's a single question screening test for drug use in primary care that we can use. And the question is, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? And that question is shown to be 100% sensitive and about 73% specific for the detection of a drug use disorder. Adherence is a very important issue in HIV. Adherence is also a very important issue in the mental health world as well, and there's been lots and lots of studies on adherence in our patients. Adherence in the HIV population is lowered by many different reasons, but the three main causes tend to be depression and mental illness, cognitive impairment, specifically HIV-associated neurocognitive deficits and HIV-associated dementia, and finally substance use disorders, which includes, of course, alcohol use disorders. And there's been multiple studies now proving that treatment of mental illness or the substance use disorder can greatly improve adherence in our population. That's one of the reasons why it's so important to talk about these illnesses when we're dealing with HIV. Now I'm going to talk a little bit about pharmacology. And just to remind everyone, all antiretrovirals are metabolized through the CYP450 enzymes, and protease inhibitors and the non-nucleoside reverse transcriptase inhibitors are metabolized and also inhibit 3A4, 2D6, 2C9, and 2C19. 3A4 and 2D6 are the two P450 enzymes that are most used in metabolism of psychiatric medications and as well as anticonvulsants. So it is important to be aware of this. Ritonavir in particular is a very potent inhibitor of 3A4 and 2D6. And ritonavir also increases glucuronidation, which also affects some psychiatric medications. So when we have a patient with HIV who happens to have depression, we usually start with the SSRIs. Those are the first line medications that we use primarily because they're safer and quite effective for major depression as well as other depressive disorders. Now, of the SSRIs, fluoxetine or Prozac and paroxetine, also known as Paxil, are potent inhibitors of 2D6, and therefore they could increase plasma levels of the protease inhibitors. In addition, they have competitive inhibition with ritonavir, who's a potent inhibitor as well. So ritonavir and, say, Prozac could actually increase each other's plasma levels. For that reason, we usually start with sertraline, citalopram, or escitalopram as the SSRIs of choice because they have little effect on protease inhibitor metabolism. Luvox or fluvoxamine is another SSRI that we use almost exclusively for OCD, and it also is a potent inhibitor of 1A2, so it potentially could increase plasma levels of PIs. We also use the serotonin and norepinephrine reuptake inhibitors, such as venlafaxine and duloxetine. They're relatively safe. They are metabolized through their substrates of 2D6, and ritonavir potentially could inhibit their metabolism and increase their doses, so wary of that. However, usually clinically, there hasn't been too many case reports of toxicity caused by these medications when they're used with ritonavir. Bupropion or Wellbutrin is metabolized through 2D6, which means that the NNRTIs such as efavirenz and the PIs, they induce 2B6, so they could decrease plasma levels of bupropion. Finally, the PI combination of lopinavir and ritonavir induces both 2B6 and glucuronidation, both of which decrease the plasma level of bupropion. Tricyclic antidepressants, which we use more often now to help with sleep, but also depression, panic disorder, and chronic pain are metabolized quite extensively through the P450 enzymes, and they are substrates primarily of 3A4 and 2D6. So, a potent inhibitor such as ritonavir could potentially increase their plasma levels. Now, that could be quite significant since tricyclics can be quite toxic in overdose, and they can also prolong QT and cause cardiac arrhythmias. Trazodone is a substrate of both 3A4 and 2D6, and so ritonavir primarily could increase the plasma level of trazodone. Mirtazapine is also 3A4 and 2D6, and so theoretically its metabolism could be inhibited by ritonavir, but there haven't been any clinical reports of this, so we're not sure. How about mood stabilizers in HIV? People who have bipolar disorder and HIV, we use several different mood stabilizers for them: lithium, Depakote, Tegretol, lamotrigine, and also oxcarbazepine is used. And generally, we can use them all with HIV. However, carbamazepine, since it's a potent inhibitor of 3A4, we worry a little bit that it could decrease plasma levels of some PIs. In addition, ritonavir, that's also an inhibitor, could increase the carbamazepine levels. Efavirenz is an inducer, and therefore it could induce metabolism in itself as well as carbamazepine, so it could decrease the levels of both drugs. We try and stay away from carbamazepine, primarily though because of the potential for bone marrow suppression and decreased white cell counts, which can be quite serious. And of course, we wouldn't want that in our patients with HIV. Lithium is not metabolized through the P450 system. It is cleared renally, so we do have to exert a little bit caution with tenofovir and regularly check those creatinine levels. Depakote, or divalproic sodium, the second most common drug used for bipolar disorder, inhibits glucuronidation, so it could potentially increase the dopamine levels. We also use lamotrigine a lot lately. It's metabolized through glucuronidation, so lopinavir and ritonavir, which induce glucuronidation, could decrease plasma levels of lamictal or lamotrigine. Antipsychotics and HIV. Well, there are quite a few people with psychosis who also have HIV, and again, quite a few people with HIV who abuse drugs who develop psychotic symptoms, and therefore we do use antipsychotics quite often with people who are HIV positive. And there's two types of antipsychotics, the newer atypical antipsychotics and the old-fashioned neuroleptics. Now, protease inhibitors, especially ritonavir, inhibit the 3A4 metabolism of clozapine, pimozide, chlorpromazine, and haloperidol, as well as risperidone. Therefore, those levels of those medications could be increased. Pimozide I have highlighted here because pimozide is a medication we don't use very often, but it does prolong QT intervals, so that's particularly significant. The problems we have with atypical antipsychotics in HIV patients is that there's a lot of metabolic syndrome that is caused by atypicals, and of course, along with the ARVs, it could be quite a problem in our patients. On the other hand, the old-fashioned neuroleptics, although they don't induce much weight increase, they do cause tardive dyskinesia, and tardive dyskinesia is a problem particularly in people with CNS problems, head injuries, and HIV-infected brains. So we worry about TD in our HIV population. How about drugs of abuse and the antiretrovirals? Well, methadone, of course, is used in maintenance treatment as well as in pain treatment, but it's easily bought on the street, and a lot of people who are opiate dependent will buy methadone. It's metabolized through 3A4, and oftentimes those who are on methadone maintenance will undergo withdrawal because Efavirenz, nevirapine, nalfinavir, ritonavir, and lopinavir can all induce 3A4 substrates, and of course, we could have opiate withdrawal. Methadone is also known to increase zidovudine levels, and of course, there's QT prolongation. Now, ritonavir is really the only antiretroviral that significantly could cause QT prolongation, but methadone is quite famous for that. And of course, most antipsychotic medications, atypical antipsychotic medications, and several antidepressants such as citalopram and tricyclics, for example, could also do that. So when we're mixing a lot of drugs here in someone with, say, a psychosis and substance dependence, we have to be careful and check EKGs periodically, or at least once to see what the baseline is, and if they're on a high dose of methadone in particular, we worry about that. Amphetamines and MDMA or ecstasy can increase levels of, their levels are increased with ritonavir. And with cocaine, both the PIs and the NNRTIs may increase plasma levels of the metabolite norcocaine, which could cause cocaine toxicity. Now, treatment of anxiety disorders in our HIV population. I've listed here the #1 treatment that is recommended, and that's antidepressants. And basically all antidepressants, with the exception of bupropion, effectively treat both generalized anxiety disorders, post-traumatic stress disorder, and panic disorder. So the SSRIs, such as citalopram and sertraline, the SNRIs, such as venlafaxine, the tricyclics, mirtazapine, trazodone, and efazidone, all will decrease anxiety levels in our patients. We prefer SSRIs, SNRIs, and tricyclics for panic disorder, while mirtazapine, trazodone, and efazidone all help sleep in anxious patients and treat general anxiety symptoms, although they are not indicated for panic disorder. Buspirone, or Buspar, is used for generalized anxiety disorder. It's a non-addictive medication that doesn't interact with hardly any drugs. And we also use that particularly when we want to stay away from potentially addictive benzodiazepines. Gabapentin, the anticonvulsant, is also used a lot now for anxiety disorders, specifically anxiety disorders in those who are drug or alcohol dependent. And it does work quite well for panic disorder as well. Prazosin and clonidine are used oftentimes for anxiety as adjunct agents. Prazosin specifically for PTSD and nightmares associated with that, but we can also use it for generalized anxiety. Clonidine also is effective for anxiety, although we mostly use it to treat opiate withdrawal. Beta blockers, such as propranolol in particular, is quite effective to treat panic disorders. And then, of course, we do use benzodiazepines, and when we're really desperate, we might use some atypical antipsychotics. We try to stay away from benzodiazepines for 2 reasons. First of all, because they're quite addictive, and our HIV population has a high risk for developing addictive disorders. But also because they're metabolized by the P450, and there's several drug interactions with the ARVs. So alprazolam, diazepam, midazolam, triazolam, and zolpidem are all 3A4 substrates, and therefore the protease inhibitors, especially ritonavir, and the non-nucleoside reverse transcriptase inhibitors will increase levels of those benzodiazepines. Oxazepam, lorazepam, and temazepam are metabolized by glucuronidation, and so therefore ritonavir and nalfinavir can increase their plasma clearance and decrease their levels. Clonazepam is a substrate of 3A4, and so theoretically its blood level would increase by the PIs and the NNRTIs. However, there have been no clinical reports of this, so we really don't know. Finally, I want to end with a little word about efavirenz. We all know this by now, but just to remind you that There are a lot of CNS side effects with this medication. Even in patients who don't have a history of mental disorders, this could happen. The most common side effect, of course, is insomnia and nightmares. But anxiety, depression, suicidal behavior, euphoria and mania, and psychosis have all been reported with this medication. So we try and avoid it in those with a history of psychiatric illness, and of course, asking about those particular symptoms is important when you put someone on efavirenz or a tripla. There are several resources for the antiretroviral drug interactions with drugs of abuse and with psychiatric medications, and here are listed 3 popular ones, including the MadisonClinic.org, which is ours, as well as the hivinsight.ucsf.edu, and of course the HIVdruginteractions.org are all 3 popular websites you can use.